Sientra implants were approved for use in the United States in 2012 and quickly became my preferred implant manufacturer based on their high-strength cohesive gel and early data. They were also the first anatomic or teardrop-shaped implant with FDA approval in the United States. Sientra does not make saline breast implants. At the end of 2021, the FDA started requiring that patients receiving breast implants sign a checklist or specialized consent form prior to being able to have surgery. Each company has their own checklist, which presents data collected through research. It was required that they publish their worst numbers, not the rosiest picture. And this data includes outcomes for patients with reconstructive surgery for breast cancer, as well as patients undergoing cosmetic surgery. One thing we know is that, unfortunately, reconstructive patients have higher complications rates. So some of these numbers are high for cosmetic surgery. When you're considering the pros and cons of having surgery with breast implants, think of this checklist as going through more of the cons in detail. Sometimes people focus a lot more on the pros of having surgery and really don't consider the long-term responsibility when you're using an implanted device. This video is to help you understand the different parts of the checklist so you can be sure you're making an informed decision about having an elective surgery with breast implants. Remember that every patient needs to sign the checklist prior to getting their implants for surgery. On this checklist, there is now what's called a boxed warning, or sometimes referred to as a black box warning. This includes that implants are not considered lifetime devices, that implants can cause systemic symptoms in some patients. This is now being referred to as breast implant illness, or BII, and this has actually been studied for decades across the globe, and still what puts certain people at risk for having symptoms really still remains elusive. Also, they include now the risk of breast implant-associated anaplastic large cell lymphoma, which is a rare type of immune system cancer that can develop around textured breast implants or in patients with a history of textured breast implants. And we'll talk more about all of these later. So this talk is going to go over who is considered a good candidate for surgery, risks specifically associated with breast implant surgery, BIA-ALCL, systemic symptoms or BII, and recommended follow-up if you have breast implants. So this is a really good list for anyone having any type of surgery, and I'll definitely go into more detail in your appointment to see if you are a good candidate for the surgery that you're seeking. A lot of these just make sense, and you should review this. Specifically for breast patients, we want to make sure that you're adequately screened for breast cancer. I think people who haven't had their kids yet should think about whether this is the right time for them. And again, people with autoimmune diseases or medications that weaken their immune system should think about whether this is a good idea. Also, there are some mental health issues that some people have, something like body dysmorphic disorder or a host of others that really don't make them great candidates for any cosmetic surgery. Unfortunately, 1 in 8 women will develop breast cancer within their lifetime, so that we do want to make sure people are adequately screened before having elective breast surgery. We recommend a baseline mammogram for all patients 35 and older. We also recommend that for patients 40 and older, they have an updated mammogram within a year. Sometimes we may also recommend other imaging studies like ultrasound or MRI. Some patients with strong family histories may be already having MRIs with IV contrast, which is a more detailed way of looking for cancer. This is also acceptable imaging prior to your surgery. It's important to know that implants on mammogram are radio opaque, which means they look like a solid white ball, and this can block some of the breast tissue from being adequately visualized with your breast cancer screening. When you have implants and you get your mammogram, they'll do some additional views to help see more of your breast tissue. They'll also warn you that the squeeze from the mammogram can injure your implant. I think it's pretty difficult to squeeze an implant hard enough to actually rupture it, but if you already have ruptured implants, it's certainly possible that the implant rupture could enlarge or get worse. So now we're going to start presenting risks of breast implant surgery. And on this first slide, I've batched a lot of complications that are true of any surgery. When you see numbers in parentheses, that is what was presented in data published by the company. And if there's a range, like if you look under pain, 2.6% to 4.5%, the first number is always from the 3-year data, and the second number is from their 10-year follow-up study. So the important things on this page are bleeding and hematoma. And if you get a hematoma, which is a blood collection around the implant after surgery, that needs to go back to the operating room for most patients. So I have, in my practice, seen this happen most commonly at about 3 weeks after surgery. Now, for a full month, we want you to really limit your activities. And sometimes after about 3 weeks, people are feeling pretty good and they start pushing the envelope and doing more than they should. Also, what's important is under infection. If it's an infection along your incision, oftentimes that's just treated with maybe an oral antibiotic or some antibiotic ointment. But if a breast implant gets infected, it's very difficult for your body to clear this type of infection, and sometimes the implant has to be removed and left out for several months before it can be replaced. Now, these risks are more specifically with breast surgery. Breasts are going to change a lot in their appearance, size, shape, consistency, or as you age with weight fluctuations, pregnancy, and breastfeeding. The asymmetry risk of 8.7 to 16.9, depending on how picky you are when you look, I'd say this number is extremely low because almost every patient is asymmetric both before and after their surgery. But this is probably relating to people who are asymmetric that required more surgery. The more breast tissue you have, the more it can droop over time, and this may be seen more with patients who have future pregnancies or significant weight loss. You can lose nipple sensation or even have hypersensitivity of your nipples or skin, and this is reported at 3.2 to 5.9%. Again, remember with these ranges, that's at 3-year and 10-year reported data. This is an important one. You may not be able to breastfeed after you've had breast implant surgery. I love it when patients are already done having kids and this is a non-issue. But if you're young and you haven't had your kids yet, you have to think what's more important to you, because up to 11.4% of people in their study were not able to breastfeed. You can also get fluid collections long-term, which are called a seroma, and this is important when it comes to monitoring people for breast implant-associated anaplastic large cell lymphoma, because that can be a presenting sign. So capsular contracture is when the scar tissue that forms around the implant becomes too tight. And this is something that has been a problem with breast implants since their inception. In the past, implants were placed above the muscle, and we know that the capsular contracture rates were much higher, up to about 60% when placed above the muscle. The textured surface did help to reduce this contracture rate. Moving implants to below the muscle also further reduced our contracture rate. We know that bacteria that lives in your breast plays a big role, and there are lots of things that we do in surgery to help reduce the risk of capsular contracture, but at 10 years it can still occur in up to 15.8% of people. These are the more severe contractures that are reported here. Mild contractures are not reported here, and it's the more severe ones that distort the shape of the breast significantly or cause pain that require further surgery. Now, you may also see or feel your implant in just about everybody, but significant rippling or wrinkling of the implant can happen in up to 4.8% of people, and you can also potentially see the edges of the implant. The less breast tissue you have, the more you may be able to see that implant. Implants above the muscle may be more palpable or visible than implants below the muscle. Now, implant malposition means that the implant ended up in a bad position after you've healed from your surgery. They all drop and they all fall a little bit to the outside. And this is specifically more a problem with patients with smooth saline implants, because the saline implants have what's called a water hammer effect, or they kind of pound or beat down because the saline is less viscous. And so these risks are more common with patients with saline implants and smooth implants in general. That was another reason why textured implants were very desirable prior to their association with ALCL. They still have a lower risk of malposition. Now, implants left in long enough will eventually rupture, and there can be some leaking from the implant, which is called gel bleed, in microscopic amounts. The old implants from the 80s were terrible with gel bleed. If you were to handle these implants in the office, they felt greasy because there was so much leakage. So still there can be microscopic leaching of some of the chemicals from inside the implant to the outside, but this is not as bad as it was in the past. And this number is really pretty shocking, that reoperation rates for patients with breast implants at 3 years was 42.5% and then 56.7% at 10 years. Now, this is a big batch of reoperations. It could be anything from as small as a scar revision or a breast biopsy all the way up to implant removal. Sometimes people have reoperations because they want to go with a different size or a different style, or maybe you're treating some of these complications already reported. So physical exam is not a reliable way to diagnose silicone implant ruptures. It's excellent for saline because salines are going to go flat, but not silicone. Mammography is also not a reliable test to look for implant ruptures. MRI without contrast can give good information about your implant, whether it's ruptured or not, or whether there's fluid around the implant. But if you're not given the IV contrast, it gives you no information regarding the possibility of breast cancer. An ultrasound can also give information about implant rupture, fluid around the implant, and it also is commonly used to assess breast masses and cysts. The thing is, if an ultrasound is ordered, we have to tell them specifically what to look for. So if they're looking at a mass in your breast, they may not look at your implant. So that has to be added to the order. Likewise, if they're looking only at your implant, they may not look around the breast for any masses or cysts that might be present. Now, an MRI with IV contrast will give you information on your breast implant as to whether it's ruptured, there's fluid around the implant, and also it's used to evaluate the breast for potential breast cancer in detail, and this is often used for high-risk patients for breast cancer. If you are diagnosed with ruptured implants, it's not considered a medical emergency, but we do recommend removing the ruptured implants and the surrounding material with or without replacement, depending on what your choice is at that time. So leaked silicone may remain within that scar tissue capsule, called an intracapsular rupture, or it may enter the breast tissue or surrounding tissues, called an extracapsular rupture. And when this happens, scar tissue will form around that silicone and form what's called a granuloma, and that may be a palpable mass. And we don't want masses interfering with breast cancer surveillance. If we do surgery to remove the ruptured implants, we typically are going to also remove the implant capsule, but that will not guarantee that all of the ruptured gel is removed. We can only remove what we see and what we can feel, but there will likely always be some remnants of silicone in your body. Breast implants are, again, not considered lifetime devices. Additional breast surgery will be required depending on the patient's age and a variety of other factors, as well as what complications that they may be experiencing. And the longer you have implants, the more likely you will experience a complication or a breast implant rupture. So again, as part of the boxed warning, systemic symptoms, or what's being called now breast implant illness, or BII, may be related to the placement of breast implants. And what this involves is some patients who receive implants complain of having exacerbated symptoms of very commonly found symptoms such as joint pain, fatigue, memory loss, brain fog, rash. I honestly have had many of the symptoms associated with breast implant illness, but I've never had breast implants. I also have a family history of autoimmune diseases, so I'm kind of biding my time before I get diagnosed. I've had some workups to date, but I kind of think it's probably in my future. Now, there's been research done for decades, and nobody has actually been able to pinpoint an exact cause or to determine why some people may be at more risk for this. We know that patients who have had their implants removed some of these patients do experience an improvement in their symptoms. Research is ongoing. I wish we had better information at this time. It's been pretty elusive over decades. It's the minority of patients, but it probably is a real thing, and patients should not be blown off who present with these symptoms. So breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL, is in the new boxed warning. ALCL is an uncommon and highly treatable form of cancer that can develop in the tissue around breast implants. This was first discovered in 1997, and the history is actually really fascinating from a scientific standpoint. And worldwide, there have been about 1,200 cases and less than 40 deaths since that time. Textured breast implants are really the risk associated with BIA-ALCL, although there have been some patients who've been diagnosed with smooth implants. The thing is, every one of these patients had textured breast implants at some point in their past. Now, the highest incidence of BIA-ALCL is in certain type of textured breast implants. Some of these haven't been used in the United States for decades, and the one BIOCell Allergan textured implant was seen to have a higher risk, and this was taken off the market in 2016. So specifically with Sientra implants, it has one of the lowest rates so far of ALCL compared to some of the other breast implant companies. And although this is bound to change, at the time of my recording this, it's about 1 in every 120,000 breast implants. So textured breast implants have been used for a variety of reasons to improve results. They were used about 80% of the time or more outside of the United States, so they were very popular. Teardropped or anatomic shaped implants all need to be textured to prevent them from rotating, and we were kind of late to the party on getting teardropped implants. I actually really loved using these, but now with more concerns of ALCL, I have really cut back on using textured implants unless there's a distinct advantage to patients and they're willing to accept this risk. Again, there have been some patients with smooth implants who've developed ALCL, but so far all have had a history of having had textured implants in the past. It's important, if you've had textured implants or currently have textured implants, that there is no indication that you need to have these removed, but you should be aware of the presenting symptoms, which are delayed swelling or fluid collections like a seroma around the breast implant, breast tightness, pain, lumps, and these can present anywhere from a year to decades after surgery, with the average presenting about 8 years after their surgery. It is believed that it is a combination of a genetic predisposition, the chronic irritation from the textured surface, and some unusual bacteria that has set up in the capsule. I think we are going to learn more about this as the years progress, but right now we want to make sure if we're using textured implants, it's for a very good reason. Unfortunately, mammogram is not very helpful in diagnosing BIA-ALCL. An ultrasound or an MRI with or without contrast can definitely help make the diagnosis. If fluid is present, it's aspirated and sent to test for certain markers that can help confirm the diagnosis. If there's a breast mass, a biopsy may also be necessary, and there are also other studies that are generally done ahead of time to help confirm the diagnosis and potential spread of disease. Treatment includes removal of the implant and the entire scar capsule. Some patients elect to have smooth implants placed, and that is actually acceptable for many patients. Chemotherapy and radiation has also been used in some patients. Again, chemotherapy was always the mainstay for lymphomas, but we find that surgery is actually one of the most important treatments. As of May 2021, there have been about 363 cases in the United States and 7 deaths. One of these patients actually refused treatment. Many patients may not be able to achieve their cosmetic goals without the use of an implant. And honestly, some patients may never reach their goals even with an implant. And I have to have a lot of hard conversations with people that just because they're electing to have surgery, they are able to look a certain way. So there's many different choices when it comes to implants, such as the company, the size, the profile, the surface, the fill, whether they're silicone or saline, the shape, and additional procedures like a mastopexy or a breast lift may be necessary. Some patients are candidates for fat transfer, and we love it when patients are good candidates for that. Generally, they want a very small increase in size, and they're also excellent candidates for liposuction, but there are definite limitations to this surgery as well. Oftentimes, I see patients who want their implants removed, and this unfortunately can result in an aesthetic result that's nowhere near what they have when they have their implants in place. It can result in dimpling, puckering, chest wall concavity can be revealed, there's sagging of the skin, and overall displeasure, regardless of whether we do further surgery to improve these results. So I know that patients don't make this choice easily, and we try to guide them about what could be done to improve their results and whether or not this is a good or bad idea based on how much they care about the aesthetics. If you have silicone gel breast implants, there is recommended follow-up. We're going to follow you after surgery until you're healed, and then you'll return to our office as needed. The FDA recommends that you visualize your implants with either an ultrasound or an MRI without contrast at 5 to 6 years after your surgery, and then every 2 to 3 years after that. Patients with a textured implant or a history of textured implants should probably have an ultrasound either annually or every 2 years, and definitely as needed. It's reasonable to anticipate needing to replace your implants every 10 to 20 years, but remember the published reoperation rates were 42.5 at 3 years and 56.7 at 10 years, so maybe my recommendation here is a little rosy.